Hi everyone, my name is Kambiz Ranavardi, co-president of ColumbiaDC and a graduate of School of Engineering and Applied Science. First, let me take this opportunity to thank our partners, Yale Club of Washington, D.C. and their members for joining us this evening. I would also like to welcome Mailman School of Public Health and Yale School of Nursing students for being with us. We are so honored to have Dr. Ann Kurth, Dean of the Yale School of Nursing, to talk about nursing through pandemic and beyond, and discuss life course perspectives to health. And we are also fortunate to have Dr. Susan Michaels-Strasser, Assistant Professor at Columbia University Mailman School of Public Health, as our host. Please allow me to briefly introduce them, but I do encourage everyone to check our site to see their full bios and references to their list of accomplishments. Dr. Ann Kurth is currently Dean and Lorimer Professor at the Yale University School of Nursing and Professor of Epidemiology of Microbial Diseases at Yale School of Public Health. Dr. Kurth is a Fellow of the National Academy of Medicine and of the American Academy of Nursing. She served on the U.S. Preventive Services Task Force, which sets screening and prevention guidelines for the nation. She chairs the National Academy of Medicine Board on Global Health. Dr. Kurth's trajectory includes BA at Princeton, magna cum laude, research in sub-Saharan Africa, public health training at Columbia University, and clinical education at Yale, and work in both private and public sectors. She earned her epidemiology PhD from University of Washington. Our host, Dr. Susan Michaels-Strasser, is a Senior Director for Human Resources for Health, providing leadership for the assessment and implementation of their programs. She is the Principal Investigator for CDC and HRSA-funded programs in the Democratic Republic of Congo, South Africa, South Sudan, Sierra Leone, and Zambia. She is a pediatric nurse practitioner and a Fellow of the American Academy of Nursing. Dr. Strasser holds an MPH and MSc in nursing from Yale University and a PhD in public health from University of Cape Town. So Susan, please take away.
Great. Well, thank you, Kambiz. I really love this opportunity to be crossing over several of our universities in terms of our networks of alumni and interest in this space. Thrilled to be talking with Susan. And so the way we proceed is I have some slides that I can share. I'd like to walk us through some highlights, and then we'll have some conversation. And obviously, we would love to get to your thoughts and questions from the audience as well. So I will attempt to share my screen now, if that can be enabled, so I can pull up my slides, if that works. Okay, it looks like that's now possible. Great. And I will go ahead and put this into slideshow mode. Okay, able to see that? Good. Well, I appreciated the title that Kambiz on his own initiative came up with, not just the traditional view of Florence Nightingale, of the lady with the lamp, but the need to be shining through this pandemic and all of the challenges that we face as a society and a species, and the role of nurses and midwives in that work. And so that's really the scope that I want to cover a bit this evening. I want to thank the Columbia Alumni Association of DC again for this opportunity. My conflict of interest are as noted. I'm a member of boards, but uncompensated. So just to kind of pose the counterfactual, I'm not sure how many of you know nurses, have nurses or midwives in your family. Most of us encounter nurses and midwives across our lifespan. I'd like you to think about what it might mean to have a world without nurses and midwives, because I think that may be a way to frame an understanding of the contribution that we make. And that contribution, I would say, is better understood these days in the midst of COVID, and also in the midst of addressing climate change and other planetary health stresses, which I'll get into describing. As you see here, the orange skies of Northern California, in terms of just the wildfires and health impacts there. And then talk for a little bit about what future are we choosing together regardless of our backgrounds and our communities of interest, we all share the goal of surviving and thriving. So just thinking about nurses, what image comes to mind? Those of you who are not nurses and midwives on this call, I want you to just think instantaneously of what image comes to your brain when you hear nurses, when you hear advanced practice nurses, nurse practitioners, nurse midwives, nurse scientists. And just to point out that this year of 2020 was designated by the World Health Organization to be the year of the nurse and the midwife. Now, ironically, because of COVID, they've actually had to expand it into 2021. And here we have Dr. Tedros, our colleague who directs WHO, pointing out the importance of nursing to all health systems in the world. This was the first year that the World Health Organization put together what is called the State of the World's Nursing. It is a report on nursing around the world in every country. And as you see here, reiterating the point that if we are ever to achieve universal health coverage, which is a renewed goal of many countries now, or the Sustainable Development Goals that the UN has set, that nurses and midwives will be crucial in that. So just as a quick thumbnail, nurses and midwives make up 59% of all health workforces around the world. They collectively, in many countries, deliver up to 80% of all primary healthcare services and many specialty healthcare services. So an absolutely crucial workforce in every healthcare delivery and public health system, frankly. A lot of the public health programming, vaccinations, and other programming is delivered by nurses. So that this is sort of a thumbnail to think about the big picture contribution. But of course, these numbers of nurses are not evenly distributed. And one of the other distinctions about the nursing workforce globally, which we are aware of, is that there is a gender divide still. So 90% of all nurses around the world are female. So there is still very much a tilt there. And I would ask you to think about what that may mean in terms of nursing being respected as a profession. We are actually a most trusted profession in the United States for 17 years running, the most trusted profession. And often that's the case in many countries. But is it always a respected profession and engaged at the highest policy and other decision-making leadership levels? And I'll ask you to think about that. But again, there is wide variability in the distribution of nurses and midwives, as you see here. In brief, the lighter numbers, the lighter colors indicating the smaller ratios of nurses to the population. And so in toto, about 20 million nurses in the world, about 19 million of those are professional nurses, registered nurses as we have in the United States, advanced practice nurses. We're 4 million strong as a workforce in the US. And just some quick snapshots from the WHO nursing report, State of the World's Nursing. There's a gap that remains. So given the multiplicity of roles that nurses engage in their communities and the health needs which are growing in a number of directions, which we'll touch on, there is nonetheless still a need to educate at least 6 million more nurses around the world, and that primarily, that gap occurs in low and middle income countries, which we saw in the previous map in a visual manifestation. So I'd like to sort of frame the profession of nursing and midwifery and the care that we deliver as sort of bookends of life, in the sense of we all want to have mothers and babies who have a healthy start to life from preconception care onward, to dignified end-of-life care. And I will just note that actually hospice, the model of hospice delivery that we're now all familiar with, was brought to the United States from the UK by a Yale School of Nursing dean, Florence. So that is a model. We had the first hospice in the country in Connecticut. End-of-life care, palliative care, very needed, very necessary, not always attained. So 80% of Americans say they would like to die at home with all their needs managed, which of course is what the hospice model and palliative care model can deliver, and only 20% actually do. And then all the days in between, and we try to think of these bookends of life and all the lifespan as a health span now. How well are we across those whatever days of life that we all have? How healthy are they? And that really is the goal. Of course, the global population is aging, and that brings both pros and cons, and certainly some health system stresses as we think about how to deliver care to people who are aging and often have a multiplicity of comorbidities. So in between the birth and the healthy birth and the dignified end of life that we all wish for, how are we preventing chronic diseases and other non-communicable diseases, and all the sequelae of those conditions that we would like to avoid? And that is the concept of the wellness span, or the health span. So this is just a big takeaway. I think many of us would agree the world does need more health workers, including nurses and midwives, and that is the case. Has been the case before the COVID crisis and continues to be the case. And why? This is just some older data that basically just illustrated a fairly simple relationship, that the density of professional health workers, and often this is only tracked as physicians, nurses, and midwives, not even thinking about all the allied health workers and health administrators and all the people who make up a health system, as well as community health workers. But even just those three professional health workers, we track those, and the higher the rate, the ratio of professional health workers to the population, the better the statistics around survival, as well as morbidity impact. So midwifery, you notice perhaps that I keep saying nurses and midwives. These are separate professions in many countries. In the US, we have nurse midwives as well as direct entry midwives. But I would just note that also at the Yale School of Nursing, I'm shameless in giving plugs, we have one of the oldest and strongest midwifery programs in the country, and some of our faculty, including Dr. Holly Kennedy, were involved in a very seminal report that the Lancet journal put out several years ago. The Lancet is the premier medical journal in the world, and they did a whole series really empirically investigating the impact of midwifery care on moms and babies and the health of maternal newborn statistics. And really, one of the incredible, to me, takeaways from that is to point out that when you educate a midwife, it's the same return on investment as childhood vaccination. So incredibly cost-effective, and also obviously a wonderful moral good to have mothers and babies survive and thrive. And so if we were able to increase the number of midwives who are educated and practicing in the world, there are positive effects on 54 different health outcomes. And if we could increase that coverage, we could prevent the preponderance of maternal deaths around the world. I will just mention, in terms of maternal mortality, it's quite shameful fact that in the United States, of all the OECD countries, we're the only one where maternal mortality has gone back and it's gotten worse. We're so used to health indices improving. This one has declined, and that is really shameful. And in addition, the maternal mortality statistics in the United States are vastly disproportionate by racial categories or racial groups. And that is to say that African American mothers have a 3 times higher rate of maternal death than do white mothers. And that's why we are very focused on the importance of Black Moms Matter and addressing this disparity, which is duplicated in other health conditions. So what are we aiming for in healthcare? We certainly need that health workforce, and I'm telling you what nurses and midwives do, but we really think about this, the quadruple aims of healthcare, which John Berwick and others have been pointing out for some time. We all want that better and improved quality care experience. We want it to be more cost effective. The United States is, of course, an incredible outlier in the per capita expenditure that we put into play for healthcare delivery, much higher cost with not as good outcomes, in fact, as our high-income country counterparts. We want to improve population health. Obviously, as individuals, we care for ourselves and our families. We want to be healthy as possible. We care about also the general population health writ large. And we have of late, and this is even before COVID, really emphasized the need to support the health of our health workers. So these are our front line for not just pandemics, but everyday conditions for prevention. And we had been seeing real fraying of the fabric of healthcare worker wellness well before COVID, and national meetings and convenings around health worker resilience, even concerned about health worker burnout and suicide. So the importance of maintaining the wellness and well-being of our health workforce is absolutely crucial, and that has only been reinforced by the COVID crisis. So if you all were asked, if we had a poll, a little polling, digital polling right now, and I asked you what you think are some of the big issues going on in healthcare in the United States, at least, I think that some elements of this list may be some things that you would bring up. We are seeing an aging population, as I mentioned. We have very pronounced and inequitable health disparities by race and economic group that we must address. And this is a national moment where structural racism and the quest for more racial justice is being discussed in nursing as everywhere. We have different delivery models, value-based care as opposed to per-piece care. We are looking at ways of utilizing technology and exciting advances like artificial intelligence and big data approaches, furthering of omics and understanding of epigenetics, and the ability to do more precision health based on someone's genetic information. The goal of living longer but living well longer, so longevity with health quality outcomes in general as an overall goal, fewer medication errors. There are a number of preventable deaths in the United States from errors. So the quality and safety of focus. We need to think big picture about structural determinants of health. The reality is we all spend a very tiny proportion of our lives within the four walls of a healthcare delivery system. And in fact, the factors that are more powerful and meaningful to us are things that happen in the broader world around us. And that's the environmental exposures that we have. That's the policies, like mass incarceration is a policy. Underfunding of public education is a policy that has health sequelae that can actually far outweigh interventions that we might try to do it from a public health department, for example. So those are the social determinants of health to think about. We talked about the need to focus on health worker resilience. And I will then move us into some conversation around, we are all focused on COVID right now. COVID is arguably an exemplar of what we call planetary health, which is to say climate change, humans urbanizing, pushing our cities into the ecosystem spaces of other species, and then we get a zoonotic spillover of viruses and pathogens from one species into the human species. We are certainly seeing that with COVID. But we're going to talk about this Anthropocene era, this human-made era that we have created and that we are in the midst of at this moment. So again, there may be any number of priorities that you care very deeply about, and many of us do. And again, these are just some of the lists. I will mention the displaced population. Nobody leaves their home, voluntarily. People flee because they have to. And we have the highest number of people on the move since World War II. And World Bank projects that with climate change, drought, strife, and other causes, that we will have potentially hundreds of millions of people who will be displaced. And we have climate refugees right now in our own country, in the United States, right? Talk to anyone in Northern California who had to flee fires. But I would say, again, the thing that we also really need to keep our eye on, because it is happening now. This is not our children's generation. This is all of us are being impacted in some way, shape, or form. Not always equitably, but all of us are being impacted by the climate crisis, climate change, climate damage, and resulting ecosystem strain. Clinicians are often respected and trusted in their communities, as I mentioned, and so that can be the case even in communities that may not have trusted role models. So it is important for us as nurses, midwives, physicians, health workers of all kinds, and non-health workers, we're all in this together, to be thinking about climate change and other planetary health stresses. The IPCC, the UN organization that shared the Nobel Prize some years back, has been, of course, tracking global warming, greenhouse gas emissions leading to the greenhouse effect, and warming of both land, air, and ocean, and the impact that that is having in a multiplicity of directions, including on human health. In 2018, fall of 2018, they put out a seminal report, which was basically the call to attention. As scientists, you know, this is a panel of many, many scientists, hundreds of them writing by committee, always quite careful in couching their language about climate change and climate damage and the impact. As you see here, the very first report didn't even really talk about the human contribution to global warming, and really just increasing certitude and alarm about what we have to do. And that 2018 report really pointed out that we have really just a decade or so of policy action, focused change, in order to keep human-induced global warming, which you see here, NOAA data and other data sources, the increased slope from human-induced conditions. If we are going to keep it to 1.5 degrees centigrade or less, but in fact, we're actually on a higher trajectory towards 2.0, and probably higher if we take no action now. So this is that idea of planetary health, and certainly I have mentioned to you that climate change is one of those drivers. But there are other factors, again, impacted by human activity, economic activity. And look, economic activity has, until COVID, had actually had incredible impact on reducing extreme poverty in the world, mostly driven by India and China, and a rise of middle class there. Actually, yeah, but the proportion of the world that was living in extreme poverty, less than $1.90 a day, had really been declining quite dramatically until we got to COVID. And now, as you might have seen from the Gates Foundation, they do their annual report, we have seen a stalling of that decline in poverty, and actually an increase in the rise in extreme poverty, as well as income inequality differentials. Deforestation and the way we use land, the water is, and the use of fresh water and the availability of fresh water, a huge problem. Eutrophication from fertilizers that's used in industrial agriculture that also leads to algae blooms and inability to use water. We're losing those buffers and wetlands that used to protect us from some of the storms on the coast. Biodiversity has been a species side. There is another UN committee like the IPCC that looks at other species impact, and the decimation of other species and the acceleration of that decimation, again, due to human activities, has been enormous. Cities, we're an urban species, and that brings both pros and cons in terms of urbanization. And the reefs are, as we all have read, are actually bleaching and dying at a much faster rate than scientists had assumed. All of these factors that are pressured by what we do in order to have our economies and our lifestyles that bring so many benefits, but have impact both directly, indirectly through ecosystem mediation, and then further displacement of populations from all these factors. So that is what we mean when we talk about planetary health. There was a Lancet Commission report a few years ago that really laid out planetary health. And this had some intellectual predecessors like One Health and the idea of environmental health and eco-health. That really those are some of those same embedded ideas. But the climate crisis and global warming, Mark Linus is a scientist who's just published a book recently. He's talked about what happens if we move towards a world of 3 to 4 to higher centigrade average temperatures. And remember, average temperatures is not what you will experience on the land or in the ocean. So there are even higher temperatures in some locales where humans are. When we look at where we are today, we all experience this, are aware of extreme weather events as one example of what happens when we've gone 1 degree above pre-industrial levels of global temperature. When we get to higher levels, and you saw the slope of the graph I showed you, where we are headed towards 2 degrees centigrade if we do not make change. Then we look at the possibility of sea level rise from Arctic ice melt and coral reefs dying off because of the warm water. If we get to 3 degrees centigrade, then there is the huge potential for food shortages. As of now, overnutrition has become a problem in the world. Obesity and diabetes and other resulting disease states because of having too much nutrition in some regards. We're going back to a place where there will be, again, undernutrition in populations and micro deficits in terms of micronutrients, in terms of the quality of food that's produced, as well as the volume. And when we get to higher temperatures, large swaths of currently human-occupied land will just simply be uninhabitable. And I don't encourage you to read the book unless you are feeling pretty resilient. It is sobering. This is the National U.S. Impact Study that was put out during this administration 2 years ago that talks about all of these drivers and how they might play out in your region. So depending on where you live, you're in the Northeast, if you're from the Northeast, or if you're online from somewhere else in the country, this does lay out the various factors and main risks that may be occurring in your region and that will be affecting your population. And these do vary, as you can see here, in terms of some of the air quality issues, the extreme weather, flooding, food, arthropod vector disease transmission shifts. Wildfires are certainly on the mind, and mental health and well-being. Mental health is a cross-cutting issue and need for all of us, certainly during something like a pandemic, but the immediate and longer-term effects of being displaced from your home, of seeing your home burn down, of seeing your community having to shift. These are actually going to increase in terms of the needs, and so we really have to think about how we're going to deliver mental health services in both the acute and long-term way. So I said that all of these climate change and planetary health issues affect all of us. In some regards, that's true, but they certainly, as with so many other health conditions, are disproportionate to communities of color, younger, vulnerable children, or older, vulnerable adults. And communities that are at risk because of unfair, social determinants of health, structural racism, economic opportunities and lack thereof. So when we think about climate change and the COVID crisis, it's a kind of example of what we call a syndemic. And this is the concept that there may be factors that actually come together and have even more powerful adverse impact, as we arguably see certainly for the effect of environmental impact and COVID in the Black community in the United States, for example. And I said COVID-19, SARS-CoV-2, the novel pathogen in the coronavirus family that has been, known about and problematic for some time, and really we've had several spillover and zoonotic events from the coronavirus family, including MERS. But when we think about the case study here, it's this pathway of humans growing and pushing into ecosystems, both for food and living, climate change and vector shifts in pathogen and diseases, destruction of the ecosystems where there might have been a balance of the factors, amongst the species. Certainly more crossover between humans and species when we think about wet markets and the trade in game, and therefore it leads to more likelihood of a new or re-emerging, often viral, zoonotic animal source pathogen that has impact. Certainly, when we think about human population, we are still on track to, we're projected to get to closer to 10 billion by mid-century. It may taper off a bit by the end of the century, but this is, really unprecedented kind of species overgrowth, if you will, and the impact of human populations, including living in urban settings with high energy needs, food needs, and every need for education and healthcare. It is a strain. Ecosystem destruction, we've certainly seen that in Brazil and other places where the rainforests are being turned into pasture land for very high energy consumption, red meat production, which is also not healthy in terms of human consumption and chronic disease development. And here again, the interplay of humans interacting with perhaps, eating a piece of fruit that a bat dropping was on, and then, Ebola can be transmitted. The trade, wet market trade is mentioned. And so really, in many regards, we have to take a sort of planetary health perspective as we think about dealing with both a prevention of these kind of zoonotic outbreaks and pandemics, and then addressing the impact of them directly as well. And again, I had said, there are great health disparities in the United States, including maternal mortality and many other conditions, and COVID-19 is certainly one example of that. Significantly higher case fatality rate amongst African Americans than in other populations. And so that is a continued concern. And that is this idea of syndemics, right? Building upon existing structural inequities and now exacerbated and enhanced by the effect of the disease. And as we know, over 1 million deaths now worldwide. 1 in 3 Black people in the United States know someone who has died of COVID-19. I hope that many of us on this call have not had to experience that, but it is distressing to realize how many people have in our communities. So I mentioned the Sustainable Development Goals. Many of you may be aware of that, put forward by the UN and others. There is a specific goal to address climate change. And obviously, I think many of us are aware of the stats. My colleague, Tony Lizerowitz at Yale Climate Change Communication Center does annual surveys of the American public about climate change, and has seen a real shift in the proportions of people, both red and blue, right and left, and the middle, who understand that climate change is happening, believe it's a problem and that it needs to be prioritized. So that has really shifted, actually, particularly in this last year or so. And so we have seen, some impact initially when COVID first hit in the spring, and there was the sort of national lockdowns. There was pretty significant impact on industrial and economic activity, and you could see it literally in the air from satellite data. Quite astonishing. The greenhouse gas emissions have climbed back up, however, of late. And as we all noted, increasing numbers of people who are being affected, including in the United States, by these conditions. So nurses, of course, have been front and center. As I pointed out to you, we're the bedrock of every healthcare delivery system. And so nurses have been called to the front line. It's really not what we're looking for, to be called heroes. What we're looking for is to be treated as professionals who are aligned with our policymakers to ensure that we have fewer of these kind of pandemics in the first place, frankly. Certainly in the early response in many countries, there was concern about lack of personal protective equipment. Surprisingly, that is still a problem in some ways as we move into another wave of COVID-19 in the United States. Kind of remarkable when you think about what we were able to do in the World War II, where we could push out an entire, ocean-going vessel every day, and we can't somehow make face masks that can be, a local supply chain. So the availability of COVID tests, of course, has been, a concern, and more testing would be obviously better. There was quite a push to many places that were hard hit with COVID, like New York City. Really, people had to come in from other places. So the ability of nurses to cross state lines and practice was really lifted during the COVID crisis. I'll just mention that nurse practitioners and nurse midwives still have some state-by-state restrictions on their full scope of practice. We're trained to deliver full scope services. We can diagnose, prescribe, treat, manage, and refer, much like primary care physicians do, or some specialty physicians do. But often some states have put restrictions on our ability to do that. During the COVID crisis, many governors just said, lift those restrictions. We need all hands on deck. So why would we want to go back to not having that? The other thing I think we've seen is the delivery of telehealth services, and that was certainly crucial during the initial response to COVID, and also difficult, right? I mean, the number of, again, we talked about dignified end of life, the number of families that had to say their goodbyes through an iPad because they could not be in the setting with their loved one. We have learned more clinically about how to manage COVID, but obviously it still is a very serious concern, and we are recognizing that there may be some longer term sequelae for people who have had COVID, and that as well will mean some care needs. There have been healthcare providers who have obviously, including nurses, who have acquired COVID in the workplace and who have died, and that of course is really tragic. We at the Yale School of Nursing have put together a toolkit for nurses that we've made available and accessible for users around the world, also trying to sort of focus on protocols that can be usable in lower income country settings. So that is one resource that is available. And we all became very familiar this last year with a lot of epidemiologic terms, R naught, and flattening the curve, and trying to ensure that our health systems didn't get overwhelmed, as we saw in many places around the world. And the goal of being able to not have that health system swamping that we were so concerned about. But I have to just share then this picture because, I think many of us are in this space right now. Oh, dear God, when will this be over? When can we go back to normal? When will COVID be done? And in some regards, COVID is with us now. It's endemic, arguably, in the way that influenza is endemic. But the bigger looming issue that we still have to address is climate change and those planetary health stresses that we went through earlier in this talk. So coming back to it, what do we do about it? Okay, this is scary and challenging and immediate and needs immediate attention. I would argue that strengthening our health systems is absolutely crucial. And there are a number of guidances that the World Health Organization and the World Bank and others have put out. The World Health Organization has always had this model of how do you build a good, strong health system? What are the pieces that you need? You need good governance. You need money, obviously. You need to be able to do efficient service delivery. You need that supply chain, and we certainly have seen supply chain problems in COVID. You need good data that you can actually use. You need that strong, resilient, trained, and available workforce, right? And now they've added, though, the need for climate resilience in our health systems to this kind of heuristic about what is needed to deal with healthcare delivery and public health systems in the context of climate change and other planetary health stresses, climate stresses. And obviously the goal is, that we try to do our part as health systems to mitigate our contribution to greenhouse gas emissions and environmental footprint. If the healthcare setting is in the United States is 10% of all greenhouse gas emissions, so it is a large sector in contributing. So there is a role to play in health systems becoming more green, if you will, and also in being ready to adapt and still deliver services and not crumble when the inevitable effects of the climate change that's already underway occurs. So we need to do both those things, mitigate and adapt. Nurses, again, are leading in this space, both locally, green units on their hospitals, as well as working with policymakers and other sectors locally, as well as regionally. We can provide anticipatory guidance to patients and populations that we serve. We have to be able to anticipate and think ahead. It's going to be a bad air quality day. There'll be more asthma, cases coming into the ED. How do we prepare for that? How do we ensure that we can continue services even if there's an extreme weather event? That focus on population health, really, Florence Nightingale had it from the beginning, understanding the importance of context in which people live, the environment that affects them. That has always been a part of our historical framing as a profession. And as a profession, I would argue we bring some good skills. Again, I'll ask you to think about the counterfactual. What if we didn't have nurses and midwives for you to see in the clinic or to bring your child to at the ED in 2 o'clock in the morning? Where would we be? We are, as a profession, I think, pragmatists and problem solvers, and we the stereotype is true. We do care about people. We do want people to be able to have healthier and fairer lives. Advocacy is actually a part of our professional and disciplinary definition. We are obligated as nurses to advocate on behalf of our patients. So that means something, that means policy, that means broader advocacy. We do lead in conducting research and applying and implementing research to improve care and practice. And we know that you can't get anywhere without working with communities and being trusted by communities. And so that collaboration and mutual respect has to be there. So I think I've walked you through, we're in the midst of COVID. It's frankly but one example of a planetary health crisis. More will come, different kinds, different patterns, but with large impact. We should be better prepared, and nurses and midwives are a part of that both prevention and delivery to address the problems. And so we know that we need more nurses and midwives who are well trained and supported. I talked about that gap. And let's take the best of what we learned from the tragedy and the difficulty of COVID in order to do a better job in the future. I will say, I don't want you to be distressed and to think only about the problems. There are things we can do. I wouldn't stay standing every day if I didn't believe we could do something to make the world a better place. This is an example of solastalgia, which is a term that's been coined about as a mental health condition, lamenting the environmental impact and loss. It's a still from Fury Road. But really, there are things that we can do and should be doing, and taking action, even at a small scale, actually is sort of beneficial to individual and population mental health. So we have a number of solutions. We can talk about doing a better job with the upstream factors, which, as we know, are very powerful. We talked about getting health systems readier, as well as contributing more lightly to the environmental footprint, climate smart health systems. The green energy transition is underway. Frankly, the cost and the investment in renewable energies is really where the smart money is now, frankly. Fossil fuels really are becoming less and less economic, much less, even with the subsidies that they get, and the fact that all the health impact from fossil fuels has never been costed into the production. The built environment, transportation, and other sectors also can be improved. So acting on climate change is also going to be very beneficial for health. So when we think about the energy sector, for example, a major study that was done recently pointed out that there are 7 million preventable premature deaths a year from air pollution alone. That's 1 in 8 of every human death. And frankly, it's more deaths than are due to HIV and malaria combined. Where's the global fund for air pollution? Right? We have a global fund for AIDS and addressing HIV and malaria efforts, but really this is a huge impact. So if we clean up those skies, it will directly save lives. Food systems, we talked about the impact of red meat is actually very environmentally stressing and also not great for our cardiovascular systems. And if we went to more of a plant-based diet, we'd have better health outcomes. Transportation, inactivity, we are seeing a lot more people on bikes, depending on how you can travel or where you can travel in your locale. If you do go to an office anymore, the ability to maybe bike there instead of driving a car can be perhaps helpful. So that Lancet Commission report that I mentioned that talked about planetary health as kind of a new subfield, if you will, pointed out that there are many actions we can take, both as individuals and as societies and economies, using water more effectively, crucial as we think about the precious nature of fresh water, ending the deforestation. Much of the carbon capture that has happened historically and that could even happen at larger scales, really will rely on natural solutions like carbon being able to be absorbed, in soil and trees. Trees are incredible in that space. There are 250 million women in the world who want effective modern contraception and can't get it. So we talked about the population growth and the pressures on the planet that we put as a species because of population growth. For people who want to space or reduce childbearing, they should have the ability to do that and the services to do that. Good urban planning is important, educating ourselves, reducing food waste, and so that we don't have to try to grow as much of it. The more plant-forward diet. And of course, as always, we need to have good policy and governance, which we do not have in every country, arguably including our own, since we are trying to get out of the Paris Climate Accord. So the planetary diet, that was another recent paper, just talking about the importance and the personal health and environmental health benefits of a more plant-based rather than ruminant meat-based diet. And maybe this looks like your dinner plate tonight. Maybe it doesn't, but at least it is an aspiration to move more into this kind of eating. So I'm just going to close towards the end here so we can get to some questions and conversation to talk about universities. We're 2 universities here, the alumni of 2 universities at least. We thought it was important to go to our universities and get educated. That continues to be crucial and important, I would argue. Not just the sciences, but the humanities and the arts have much to contribute. Business, law, all of it has to come into play as we think about the massive social and economic changes that we need to make to get through COVID and to get through the climate crisis that is upon us. Certainly linking our health systems with, and public health systems with our universities and our health science schools is important to keep that flow of new knowledge and improvement going. We need those partnerships though across industries and sectors. Many universities have come up with sustainability plans, and of course Columbia has the Earth Institute and the Earth School, that has engagement across the university. Yale had one. It is a university that was one of the first to do carbon charging on campus. So we are pushing our sustainability plans and trying to maybe move our net zero deadline goal date down. I can't preempt President Salovey, but I'm hoping that we are going to be moving forward more in that space at Yale. University to university networks around the world, I think, can be powerful, especially when we have such devolution to a nationalistic viewpoint. We're not cooperating across national borders, but pathogens move across national borders. So almost that people to people and university to university, faculty and researcher to researcher connectivity, I think is something that's very precious and that universities should continue to nurture, because we don't always see it in the corresponding political space or geopolitical space. Alumni, of course, are crucial, and I'm not just playing to the audience. We're tens of thousands of engaged and interested people around the country and often around the world who often want to learn and think about these issues and care about our own and future generations. So at Yale, we are thinking about these issues, and we're convening it under the rubric of what we call planetary solutions. And we're bringing together across our disciplines and across our schools and across our campus people who are interested in contributing in some way to some of these issues and solutions that I've outlined here. If we were to think of what we need to do as a species, arguably we should need to clean the grid and electrify everything. That's one approach. You need better batteries for that. So, there are all kinds of people at a university like Yale or Columbia that are engaged in this very interesting work. Everything from, understanding frog species decimation to better urban design and everything in between. So we need to do that mitigation piece. We need to think about resilience, and we've talked about needing resilience in the healthcare system, but certainly across the sectors that many of our at Yale and Columbia faculty are engaged with. And then we need to adapt. So getting our health systems and other sectors ready for the inevitable impact that we're already seeing. So I'll just close by saying, I am a hopeful person. I think that is a nursing trait, as I mentioned. I think that we have the opportunity to think about where we want to go in the immediate future. And do we want to have, Fury Road in the dystopia, or do we want a better world for ourselves and the other species on whom we also rely? And so I'll just close with, giving a nod, and I know Susan can speak to this as well, in having worked with so many places around the world, including with the HIV pandemic, that we learn so much from the tragedy of HIV, including the advocates who really changed the way we think about approving drugs, FDA approval processes, the science behind it, the engagement of people as people living with HIV, not just patients and their providers. That kind of real demanded partnership has all of that advanced. All of that has advanced. Really has benefited the whole world, not just those of us engaged in HIV work. And we really owe a lot to the advocates who push that forward. And so when we think about how we move forward now in COVID and with climate change, there is a lot to learn from the wisdom of the HIV advocates about how to organize, about how to make change, about how to collaborate, about how to push, and recognizing that we are in fact all connected. And I think we all feel this in some space inside of us. The world has to be different. Beyond COVID. There will not be a 2019 that we return to, but we can and must do better. And I believe we can. Nurses and midwives are part of that, but so is every single one of you. And I'll just close there and move into discussion.
Wonderful. I feel like giving a round of applause, and you've covered a huge amount of information in a relatively short period of time. I always learn so much when I listen to you, and thank you for pulling so much together and bringing it into one story of how we are all in this together and how we have to collaborate, not only to drive health, but to drive survival. And it's sobering indeed, but this whole year has been sobering, and I really appreciated that you ended with the story of how to end a plague. And I think for both of us, this has been our career trajectory. We both came into nursing around the time of the HIV crisis, and when nothing was known, there were no treatments. We didn't even know what it was. And now working in this space, we are getting to epidemic control without a vaccine. And people in the most remote parts of the world have access to life-saving antiretroviral therapy. It is a miracle in so many ways in just a few decades that we have gone from something that was nearly destroying most parts of sub-Saharan Africa and now is thriving with medicine and without a vaccine. So thank you for your wisdom, your science, and bringing it through the lens of a nurse. It really warms my heart, and as a nurse, but also as an academic, that you bring this human component to the discussion of science. I want to start out by asking you about reflecting on this past year. I've always known that there is politics in public health and in healthcare, but this year it's come so acutely obvious, the politics of health and the politics of public health. And I wanted to ask you, why do you think that is? Why do we commingle these so much?
Yeah, I guess thank you, Susan, and I so appreciate your history and perspective and all the work that you've done, which I would like to be able to have you share a little bit with this group and working with providers around the world. I guess if I'm hearing you correctly, you know, why have we politicized what should be a straightforward use of science, trusted and consistent communication, and allocation of resources to prioritize the needs that are right in front of us. And you know, I think there are probably a number of factors to that. It is clear that we've become more, at least in the United States, and I think we are a somewhat unique case right now, but not entirely. You know, a turn to more autocratic governing styles, a denigration of science, and to the extent that it allows those fissures to be actually you know, exploited. The tools of communication in social media that can be that hijack our very brains and turn us towards tribal, you know, sort of my group behavior, as opposed to being leveraged for you know, opening our brains up and saying, well, this is actually behavior that I can do that will help me and my family. Mm-hmm. I always say, if public health could like harness just 1/10 of what you know, marketers and frankly you know, sort of media sources can do with their audiences, we'd be in such a better place, you know?
For sure. And you talked about the numbers of deaths from COVID-19, and it didn't have to be this way. And I think, you know, we're both from the tri-state area, New York, New Jersey, Connecticut, and we've seen the role of leadership in driving that, what you talked about, flattening the curve here, when New York was the epicenter and now is a model of how to keep the numbers low, data-driven approaches and strong, consistent messaging. But nurses have paid a serious price, and all health workers and all frontline workers in general have had repeated exposure to the social determinants of health, those disparities, the suffering, having to say goodbye through an iPad. And I'm wondering, what are your thoughts at the Yale School of Nursing? What do you think we are going to see in the next year or 2 years as far as mental health of frontline health workers? What are you thinking about at Yale? What are some of the things that you're looking towards as potential concerns and problems? Yeah,
no, thank you. You know, the mental health and resilience is, again, we've been concerned about it for quite a while. I was looking at a systematic review, a paper that was published the other day about healthcare workers. You know, as healthcare workers, often we don't want psychiatric interventions or psychological. We want socialization, and time off. You know, and part of that is that we kind of don't partake of our own medicine adequately enough. And, there is still an unfortunate stigma or this idea that we have to tough it out, and that's absolutely, you know, not healthy, right? That said, I do think we actually are going to really need more interventions, and so certainly at Yale, at Columbia, and in many settings, you know, we encourage our health workers and our faculty and students to utilize, you know, available mental health services. We're delivering them both in individualized and group ways through telepsych, right? So that utilizing best practices around getting services in place, even if we aren't physically in the same room with each other. I will actually mention that, you know, one of our faculty, Dr. LaRon Nelson, has been thinking about this, and given that we're going to see both acute and long-term impact of all these climate change and other stressors, we're actually beginning a partnership with some colleagues around a brief intervention that the Department of Defense uses. That can be delivered in a couple of weeks' time. It's not a super extensive long course of treatment. The training is pretty straightforward, and it does have some empirical evidence behind it. And we're thinking about really how we might need to scale that up as one delivery tool, both in the United States, but also we're working with partners in Rwanda. We actually just recently completed for the National Academy of Medicine. I chaired a wonderful evaluation committee that PEPFAR funded for the PEPFAR contribution to the Rwanda Human Resources for Health project, which was quite significant and unusual, trying to rebuild Rwanda's healthcare post-genocide to address HIV and other issues. So we're now working with partners there as well as they think about the mental health needs. As you know, Susan, you know,
Yes.
mental and dental health is often left out of global health care, and yet is so crucial, both for obviously health workers as well as the general population.
Yeah, and it's really been highlighted very poignantly in the US and here in New York at Columbia, with one of the doctors that led one of the New York Presbyterian hospitals committing suicide. And it's a harbinger of that repeated stress and those traumas. And that happens, as you said, worldwide, is something we haven't historically dealt with, not only in the aftermath, but preemptively. And I'm thinking, you know, this is a time for us to rethink how, amidst crises, do we anticipate, you talked about anticipatory guidance, how do we anticipate the needs of health workers in real time and give them a way to debrief and to address those stressors and those micro traumas as they're going through a pandemic. And it's very interesting to hear about, is it LaRon Nelson's work? Wonderful. I know there is evidence-based mental health strategies like trauma-focused cognitive behavior therapy, and there's so much to be done, especially now with this syndemic, as you talked about.
And not neglecting too the needs of our students, right? So, you know, fortunately, we have students who are going into healthcare, even in the midst of this COVID crisis, and thank goodness. And you know, in the United States, I think this is true at many of our universities. You know, even before COVID, about 40% of our graduate students already have pre-existing, you know, mental health needs, and so then you add this on top. So being able to build that resilience and be anticipatory and try to help our students thrive as they get through their training, because we absolutely need them out in the workforce to replace all of us and to meet the gap that's there as well, right?
Yeah, exactly. As we get on that other side of our career lifespan, and having people that have that passion and that energy to bring to the is ahead.
And they're going to do things differently too. You know, I mean, they're really, you know, this national moment of reckoning with structural racism that we've all sort of let lay for centuries. This generation won't have it, and
they won't stand for it. Exactly.
They'll do things differently, you know, and that should have an impact, I hope, in a structural way in health systems and elsewhere.
I believe so, and it gives me a sense of hope. There are some questions coming in. So the first one is more of a comment from a nursing colleague who talks about how nurses' voices need to be in policy and politics. And she does global health work in Rwanda as well, empowering women in rural communities, and wants to explore how we can collaborate. And this is Dr. Harriet Fields, and it would be great, Harriet, to meet you and discuss. I've got your email here. But how do you think nurses can get more engaged in politics? You talked about nurses being pragmatists and practical and getting things done, and I completely agree. And wondering how we can push more women and more men who are nurses into public policy space.
Right, yeah. So I mean, in the United States, 2% of the voting public are nurses, right there. And then actually, we have some doctor of nursing practice students, two wonderful doctor of nursing practice students, one of whum ran for office and one of whom was our campaign manager, who were going to, as part of their project, and you know, with the endorsement of us at the School of Nursing, they were going to do a nurses candidate school. There are about 400 candidate schools in the United States, yes. Not a single one of which is for nurses. And so prior to COVID, we had it all planned for June. There was going to be a 5-day intensive about how to run a campaign, how to, you know, even if it's for your local school department, you don't have to go to Congress, as increasingly some nurses have, and some young and dynamic women have gone into Congress. But so, you know, I think there is that exercising our ability to vote. I worry that I think sometimes the boomer generation believes like democracy is wonderful and we should exercise our vote, and I'm worried that maybe some of the more recent generations are quite cynical about it. But while we have it, we must exercise it, and then also get engaged ourselves, not rely on going to Capitol Hill or our legislators, which, you know, they do listen to nurses and they listen to their constituents, but why not be that policymaker as well?
Mm-hmm, mm-hmm. I completely agree. Let me see, I have got another question. What do you think the COVID-19 pandemic, and I'm going to shift after this to more around planetary health, but what do you think the COVID-19 pandemic has taught us about nursing?
About nursing, you know, that we have got to be more engaged in I think more preventive work, that we have got to cross over with our public health colleagues more effectively. You know, in some regards, we have a handbook for how to deal with pandemics, and yet it sort of went by the wayside.
Yeah.
And I think, you know, in part, you know, it was we've come to accept or have to live with health systems that really are right on that margin, right, of it is all about elective surgery and just-in-time supply chains. Yeah. And we found in this, that's not going to cut it. You know, you need to be able to, so some of those, you know, just some of those principles that we appreciate in nursing around prevention and systems thinking and, you know, being prepared, I think are going to serve us.
Mm-hmm. And I think if you polled nurses in January of this year, many would have anticipated what has unfolded, knowing the system weaknesses, knowing the workarounds, the just-in-time procurement, and the fragility that is there, trying to pull it all together despite the, you know, the forces that are often working against you in the healthcare delivery. There were a couple things you said that really hit me hard. The first one was about training midwives, the return on investment being equal to child vaccination. I hadn't heard that before, and that is because I see childhood vaccination as probably the public health miracle of the last 100 years. I mean, things that we don't see anymore in the United States, but which you and I have both seen elsewhere. I've seen children die of measles, of polio. I've even seen tetanus in newborns. And these are things we often don't even think about anymore in the United States. And to train a midwife has that same return on investment is simply amazing. And then you also said how during COVID, a lot of these barriers to nurses' full practice fell away because of the necessity. And I think there's a moment now and that nurses can push forward. What would you say to nursing leaders out there about this time and taking opportunity, using this time as an opportunity to push, not for nursing only, but for health and for access to quality health care?
Exactly. And, that is exactly the phrase. I don't want you to think of nursing. I want you to think of health. Do you care about health? Well, then you should care about nursing. But because I think too often we get sidelined, and there was a study called the Woodhull study that was done a couple years ago. You're probably familiar with it, about the representation and engagement of nurses in the media. And it was about 4% of articles about health, either featured by name or called out the content expertise of a nurse, even though, as I told you, nurses are 60% of the health workforce. They repeated that Woodhull study a couple, just more recently, and it was 2% of nurses. So, I would say that we have to be vocal about what we know and what we know is needed, and to advocate for that, and really to dig deep, because we are all tired right now. We've still got a road ahead of us. And that road has to be in a different place than where it was behind us. And so I think that some of it is really even just that headset of digging in and saying, this is a moment that we have to seize as a health sector, but also really as a species, and that we can do it. We can turn some corners.
Yeah, and history has shown that. And you're reminding me, I'm mad at myself some of the time because I didn't speak up louder about masks. In February, we were sitting in front of the television and hearing people at the national level saying, don't use masks, they won't help. I know that was largely because of concern about the scarcity of masks, and they didn't want people to go out and hoard masks. But that completely missed the mark. And I knew a mask, it can't hurt. We still were learning about the virus, but it just, common sense of nurses knows that any type of barrier could be helpful. And so I think to myself, I should have spoken up more loudly. And that was an opportunity, a moment, and we need to capture those moments.
And also nurses know what quality care is, and that's why there's such high moral distress for nursing, right?
Yes.
There is enormous moral distress amongst nursing and burnout, because we know what we should be doing and be able to do for patients, and often we can't. There are systems barriers in our way. Oftentimes there's moral distress amongst physicians, and I'm talking about this is from the literature. These are evidence-based studies. For physician, the moral distress is sometimes a little bit different. It's about lack of autonomy. That there used to be more autonomy for physicians, and now, but it is that moral distress, and so again, we know often what needs to be done and what should be advocated for, and so we can't lose that focus either.
And that dissonance in and of itself is a stressor. There's another question that came in. Were the objective to diversify nursing to include more men? Is that a worthy objective? And how can we do it? Policies, trade schools. I was talking with some people this morning. Actually, LaRon Nelson was part of that talk about bringing in more men. And you talked about the majority of people being in nursing being women. What do you think about that, pushing and being intentional about bringing in more men to nursing?
Yeah, I mean, it's just, it's a mystery to me in a lot of ways, right? I mean, I always say nursing is one of the best kept secrets, you know, in the country. It's a great career. It's the top third or top fifth fastest growing, you know, yeah, it's the best career path to go into. We are seeing applications in nursing schools and medical schools going up right now in COVID, which is interesting.
Interesting.
So I've just never understood it. And as you know, working in other countries, there often are more men in the nursing workforce than in the United States. And I just have to believe that some of it just comes back to misogyny, or it's a genderized discipline still, even though, you know, it's growing in stature and obviously respect, and it is a science-based, it's a STEM or STEAM-based, you know, discipline. We include the arts as well as the sciences. It should appeal to everybody who is interested in the world and wants to make change. And it's such a great and flexible career. And as you know, the stats show that men in nursing actually tend to rise faster than women. Pay differentials, which is another issue aside. But there are, as you know, there are programs that are trying to sort of get at best practices that will encourage men to go into nursing, that will, you know, encourage schools to do a better job with that recruitment and training and recruitment. And I think we need, you know, nursing, like other sectors, we need to reflect the diversity of the people we serve, and that's everyone, right? That's male, female, non-binary. It's everyone, and certainly all groups need to be bring their richness of experience to nursing.
I couldn't agree more. And having a wide variety of people just strengthens the profession, strengthens the understanding, the humility that is brought to the table from diverse backgrounds. And as two nursing leaders, to the group, that people listening, we want more people in nursing, we want men in nursing, we want diversity. So please encourage your friends and colleagues to think about, advocate for nursing. Another question which I find interesting is, what is the interaction or intersection between nurses and social workers? And I know that nurses, especially nurses at the turn of the 20th century, were very socially minded and very engaged in social determinants of health, like Lillian Wald, who went on to develop the visiting nurse service and children's health programs. And so what do you think that intersection is between social work and nursing?
Oh yeah, I mean, it is true. I mean, and certainly, as you know, in HIV care, there's just no way to do quality HIV care without having a whole team, right? You know, it's the nurse practitioner and the nurse and the ID doc and the social worker and, you know, the pharmacist. I mean, it's absolutely crucial, and social work has always had, as you say, that very fundamental appreciation of the social determinants and the upstream factors and how to address them. So, you know, dealing with a person holistically. So I think we probably do a disservice when we talk about interprofessionalism in education, and we're really thinking in our minds, oh, let's get doctors and nurses to get to know each other as students. It's a very limited kind of view, right? I always laugh when physicians say, well, yeah, we're interprofessional. It's a surgeon and a you know, a hepatologist. Like, no, that would be other professions, right? Yeah. And so you know, I think probably, and this is this idea of what can we do differently and better as we go move you know, into this COVID world and past the COVID world. Why are we not doing more interprofessional education? Some of it, frankly, is an engineering problem. It's a scheduling problem. How do you get people in the different programs to be able to be in the same classroom, right, in the same day? Well, we can maybe do a better job of that now with technology, and I think we do need to broaden our framework around interprofessional and team-based education, because we know that team-based care delivery has better health outcomes, and team-based science actually is a richer, often has richer outcomes as well. So, yeah, we do need to do a better job with that.
It's interesting that this question came in and your response, because I was watching a PBS documentary about the Mayo Clinic, which is considered the #1 hospital in the United States, and the Mayo family, the father and two brothers who developed the Mayo Clinic, very much believed in a team approach between the nurses, the doctors, and allied professionals working together, coming together, discerning, and their success obviously is written in history. So let's move to the climate crisis. What do you think about bringing different fields together to tackle climate crisis? And it's not just about those in the health field. We're talking about economic policy, engineering, city planning, urban planning. There seems to be a time now where we have to think well beyond the healthcare team to a much wider team to drive health for the planet.
Absolutely, and that's where I say universities are they're a gift to the world, right? I mean, and there's a reason why it's almost a 1,000-year institution in some form or other, right? Corporations are only about 250 years old, right? So there's something about universities that is precious and rich, and I think it is that you have all these lines of human endeavor in this small space. Of course, now it's more of a virtual space for many of us. And that has been incredibly productive, and yet I think we now have to get more applied than we are comfortable with or always used to in the academic setting. One of the things we've learned from COVID is, you try to get a curricular change at a school, and it's how many committee meetings for how many years to get one syllabus. Suddenly, in the spring, we all pivoted and had to deliver online education, both the pedagogy and some of the clinical simulation and other clinical education. Yeah. We did it in a couple of months. Now we've got to make sure it's best practices and learn from all of it and keep improving it. But it is possible to move more quickly, even in the new knowledge generation application, learn from that and improve. We are very much in improvement cycles at health systems. All of that has to happen on a very accelerated pace now. And again, I would rely on universities like Columbia and Yale, but all of them have to have some role to play in that. We are, our students pay tuition, or the taxpayer pays for some of the research, and it needs to now apply to improve these, to address these existential crises. It can't be about, you've done your 6-year randomized trial and you've published one paper. It has to move more quickly, and that's something else that HIV taught us, that it could be done more quickly.
It can be done, and I think, as you talked about, that's what gives us hope and gets us up each day, because you talk about things that are an existential crisis. When you talk about the difference between 1 degree temperature increase and 4 degrees, it's a bit mind-blowing. And I think what I'm taking as a silver lining from this horrible, very difficult year is that we can change, and we can change quickly when we need to, when we're forced to. These artificial barriers to change fall away, and I think that's something we've got to remember going forward. We can drive change. It's getting to the point where people see the immediate need for that change. Al Gore, a proponent, obviously someone who has been long in the climate challenge, has a quote. He said, "It often feels that things will never change, and change is very slow. But when it begins to happen, it happens faster than you ever thought it could." And that has always given me hope, and I think you're highlighting that here. If I could grant you a wish in fantasy, what would you hope for as far as the climate crisis to come out over the next couple of years? What are you looking for?
Well, I guess more cohesive consensus of the importance of action and collective action. And I think some countries lead in that space and others are lagging, and we need to all move forward. I think that the green energy transition is going to happen. I think the economics of it simply will move some of that in the right direction. I think the thing to watch for is the equity question, because this is a huge equity issue. Not everyone is affected equally. The ones who contributed the least to this problem are the ones who are being hit hardest and first right now, like as in low and middle income countries. And so if we continue to do this sort of my my group, my country only perspective, then we're not, if we don't link arms as a species, we'll all go down with the ship. And so I hope that people in some instinctive way do understand that and move towards more collective action.
And I think COVID has really hit home how small the world is. I mean, a virus could travel the world in a matter of weeks, barely months, and get all around the world and catch us all off guard. And we really are all in this together. It's been a very sobering year. If you were able to add something to the curriculum for nursing and to push the agenda there, what would you put in about planetary health?
Well, we are actually working at the Yale School of Nursing with the Healthcare Without Harm, which is an international nonprofit. Gary Cohen, who's a MacArthur Award winner, is one of the founders. They work with health systems around the world. We're working with Healthcare Without Harm and the Alliance of Nurses for a Healthy Environment, ANNE, which is one of the oldest environmental nursing groups, to put together some continuing education modules about planetary health and its implication for nurses and other health workers, because again, many of us have to maintain our licenses, so we are motivated for lifelong learning and we have to get our continuing education credits. So we are going to put that together and then make that available. Yale has relationships with Coursera and other platforms to make it available to the world, to those 28 million nurses. Right. 4 million nurses in the United States initially. It'll be domestically focused, but we are trying to put together some materials that could be utilized by practicing nurses.
That's great, excellent, and really bringing it right to the practitioner. And as you said, nurses educate patients and families, and in their work, they can be educating people as families deal with asthma and increased air pollution manifested through disease. They can be not only treating and helping to care for the asthma, but addressing what is behind this, what is causing this, sensitizing people, increasing awareness. Let me just check my notes here. Could you talk a little bit more about your work with the National Academy of Medicine, what you've been involved in?
You know, yeah, thanks for asking about that. Actually, just this last week, the National Academy of Medicine has an annual meeting. And frankly, in the past, it's always been a very little insular event that the fellows, there's a couple of thousand National Academy of Medicine fellows come together and have in-person meetings. And this year, for the first time, it was open to the public. So I would encourage, I believe that the talks were streamed online. So National Academy of Medicine, we did make the focus of this year's annual meeting climate change and COVID, the existential crises. So we had Bill Gates, we had Tony Fauci. We had some great talks, both on the science and the policy questions. So I would just mention that as a resource. There are national academies of medicine around the world, and one of the speakers at this NAM meeting is Sir Andy Haynes. He's working with 147 other national science academies around the world on climate change. So again, that idea of coming together across our scientific venues, including universities and science academies, is important.
And those are recorded, those proceedings, and available? Yeah,
they should be. I haven't looked in the last couple of days, but they should be available online there. And so
excellent.
Yeah, that would be
great. We just have a few more minutes, and I want to end where we began, the year of the nurse and the midwife. Your comments about what 2020 has meant to this celebration of the bicentennial of Florence Nightingale's birth and 200 years of nursing. And as you said, Florence Nightingale was a public advocate, a person who embodied so many of the things that you talked about and really driving and challenging us to do as nurses in creating healthy environments and healthy communities. What would be your final comments around this year, 2020, the year of the nurse?
I would say we're all going to remember this year as a pivot point for the species and for the planet. I think that everyone is really touched by a nurse in their life, in direct and indirect ways. I was shocked because when would I ever quote Boris Johnson? But you know, he named his nurses by name and said they're the ones who saved me. Right? They were monitoring my respirations. They were, you know, looking at my vitals. They were making sure they were the ones who actually saved my life. And so just don't think of nursing as the lady with the lamp, because it could be anybody. You know, it's not just females, but it has a validity, even if it is mostly a female profession. But the lamp we're lifting is the one that's going to help lead us all out of darkness. And so if you care about health, you should care about nurses.
Yeah. Yeah. Yes, thank you. And that presence of nurses at the bedside, in the community, watching all of us as we literally breathe and as we metaphorically breathe as a society. Nurses are there watching and asking difficult questions about what is driving health. Thank you so much for the expertise that you've shared, reflecting on this. You give me energy. So
thank you, Susan. So good to see you.
And fight this good fight. We're in this together. COVID has shown us this. And so thank you for all that you do. And thank you to the Columbia University Club and the Alumni Association for helping to make this happen.
Yeah, and then thank you, Ann, thank you, Susan. It was an education. I would like to let everyone know that we have recorded this event. After processing in 24 hours, it will be posted on our YouTube channel. There's great content, so everybody receives an email. We will let you know. Thanks so much for your time. And I just want to mention that I apologize for putting a lady with lamp.
No, it's a metaphor.
That's okay.
Which was actually an education when you explained to me that you know, you're coming out of that paradigm. It was it was the start for me to understand. Thank you so much.
Thank you. Appreciate it.
Bye.
Thank
Bye,
you.
Stay safe.
Good night. Bye.